coronary artery occlusion from Kawasaki's disease. Kawasaki disease, also called as mucocutaneous lymph node syndrome, is a vasculitis of unknown etiology that generally occurs during infancy and childhood. KD also occurs rarely in adults. It is typically a self-limited condition with fever and manifestations of acute inflammation lasting for an average of 12 days without therapy. However, complications such as coronary artery aneurysms, depressed myocardial contractility and heart failure, myocardial infarction, arrhythmias, and peripheral or arterial occlusion may develop and lead to significant morbidity and mortality. Non-cardiac complications may also affect children with KD.
The coronary arteries are the blood vessels that supply oxygen to the heart muscle. Because the heart muscle is always contracting, it needs a steady flow of blood to bring it nutrition and oxygen. When children develop Kawasaki disease, the walls of these arteries become inflamed. If we could go inside the blood vessels, we might see something like this. Normally, a cell layer called the endothelium protects the vessel wall and prevents blood cells from leaving. However, some trigger during the development of Kawasaki disease causes the endothelial cells to become activated and causes cells of the immune system to stick to the endothelium and leave through the blood vessel wall. Inflammation in the vessel wall is caused by immune cells gathering in the wall and liberating chemical signals that recruit more cells and further damage the vessel wall. Intravenous gamma globulin, or IVIG, interacts with these cells to quiet down the immune response, although the exact mechanism of how this is achieved are poorly understood. When inflammation occurs in the vessel wall, it causes the artery to dilate. About 1/3 of children in the early or acute stage of Kawasaki disease will experience dilated or widened coronary arteries. If the patient is treated with a protein solution called gamma globulin, or IVIG, within the first 10 days after fever onset, the chances of the dilated artery returning to normal size without scarring are excellent. However, if the inflammation is treated late, or the IVIG infusion is not effective, permanent damage can occur to the arterial wall. Sometimes this results in a ballooning out of the wall, called an aneurysm. This ballooning of the vessel causes the blood to swirl and increases the risk of blood clot formation. If the blood clot continues to grow, this may result in blockage of the vessel and a heart attack. In many cases, scar tissue will begin to form in the aneurysm over time, and the blood vessel will heal. However, the blood vessel is never again completely normal, and many years after Kawasaki disease, scarring could lead to narrowing of the vessel and again present a risk for heart attack.
The major complication of KD is coronary artery abnormalities, which can include dilation, aneurysm, and/or stenosis. Patients can also develop depressed ventricular function in the acute phase, valvular regurgitation, and pericardial effusions. Late cardiovascular complications include progressive coronary artery stenosis or occlusion, myocardial infarction, and arrhythmias. These late complications are generally limited to patients who had CAAs in the acute phase. Acute myocardial infarction is the main cause of death in KD.
%80 of the patients who have Kawasaki disease are under 5 years of age. So occasionally it is seen in older children and adolescents, and even occasionally in adults. But the majority of patients are children, and especially young children. These children then will be followed by a pediatric cardiologist, even if they're initially treated for the Kawasaki disease, and they get their gamma globulin infusion, which is done in hospital overnight, usually, and they get their aspirin by mouth. After that, after their first ultrasound of the heart or echocardiogram is done, they will go home on low-dose aspirin once a day. And then a few weeks later, they'll come back and see the pediatric heart specialist again, the pediatric cardiologist. They'll do another echocardiogram or ultrasound of the heart and look to see if there's any complications that have been left behind. Generally, they'll have a third echocardiogram about 6 to 8 weeks out from the initial illness. And if that echocardiogram at that time is normal, then the aspirin will be stopped and they'll be discharged from further follow-up. If that echocardiogram at 6 to 8 weeks shows the complications in the heart that Kawasaki can cause, the aneurysms in the coronary arteries, the arteries that supply blood to the heart, then those children would stay on aspirin for a year and continue to be followed by the cardiologist, the pediatric cardiologist. The good news is that at the end of that year, the majority of patients who had coronary aneurysms at the beginning of that year will no longer have them at the end of the year. So that is the good news, that in the majority of patients, even if it does have the complication of coronary artery aneurysms, they will go away after that first year.
The frequency of CAAs in KD and the associated mortality have decreased dramatically as a result of intravenous immune globulin, IVIG, therapy. Patients treated with IVIG within the first 10 days of illness have an approximately 75% decrease in the risk of developing coronary artery aneurysms and a more than 95% decrease in mortality. While CAAs occur in approximately 1/4 of KD patients, in the IVIG era, most of these patients have a small reversible coronary artery dilation, not true aneurysms.
Kawasaki disease. This is a rare condition, and it usually occurs in children who are less than 5 years of age, and occurs more so in boys than it does in girls. In the United States, about 4,000 new cases are diagnosed each year, and the condition is most common in Japan. It is also the leading cause of acquired heart disease in children. But what is Kawasaki disease? It is an inflammation disease of the blood vessels, medically termed vasculitis, but also the lymph nodes, mucous membranes, and even the heart. The cause is unknown, but we believe that the trigger to the development of this condition is exposure to an infectious agent. Kawasaki disease is not a hereditary condition. What are the symptoms? The classic story is usually that of a child with high temperatures, 103, 105 degrees, for more than 5 days, and is associated with swollen eyes or conjunctivitis, cracking lips, strawberry-colored tongue, sore throat, swollen glands in the neck, red palms and feet, joint pain, peeling skin, and rash of the trunks and limbs. Other non-specific symptoms include irritability, nausea and vomiting, cough, and runny nose. The fever may last at times more than 2 weeks. Complications that may mean heart involvement include shortness of breath, chest pain, and symptoms of congestive heart failure, like swollen legs, unable to lie flat in bed because of shortness of breath, suddenly waking in the middle of the night with difficulty breathing, and easy fatigue or shortness of breath with exertion. How is the diagnosis made? Good history taking and physical exam are the most important steps for early suspicion and eventually the diagnosis of Kawasaki disease. The physician will order blood tests like CBC, sed rate, C-reactive protein, urinalysis, etc. But no specific test can make the diagnosis. It is made by the combination of history and physical exam findings. If the physician suspects involvement of the heart, then an echocardiogram, which is an ultrasound of the heart, will be most likely performed. An EKG, or electrocardiogram can show signs of myocarditis or pericarditis. A cardiac catheterization can detect aneurysms, which are weakened and dilated blood vessels in the heart or the coronary arteries. Also, by putting a dye into the arterial system by cardiac catheterization, the heart can be looked at directly and the arteries can be visualized.
In Ecuador, according to the National Institute of Statistics and Census conducted in 2013, corresponding to hospital discharges was a total of 36 cases. However, these statistics are considered uncertain, since there are hospitals and pediatric clinics in which they don't do surveys about this disease.
What is the treatment? Because of the potentially life-threatening complications of Kawasaki disease, these children are usually admitted to the hospital for management, diagnostics, and treatment. Treatment must be prompt and aggressive to prevent the development of aneurysms in the coronary arteries and the heart. High-dose IV gamma globulin is the standard therapy and can see results as quickly as 24 hours from the start of treatment. High-dose aspirin is also given, a very peculiar treatment because we now rarely use aspirin in kids due to the potential development of Reyes syndrome when used for other viral infections. Even when appropriately treated, up to 1/4 of all the kids with this disease will develop problems in their coronary arteries. Some recent research suggests that using steroids might improve the outcome, but the data is really not conclusive. If the coronaries do become diseased, the management is similar to that of an adult. That involves cardiac catheterization with balloon angioplasty or stent placement. Even cardiac bypass might be necessary. 1% of all patients with Kawasaki disease will die from their complications, one of which, not mentioned before, can be a heart attack. Yes, you heard it right, a heart attack in 5-year-old kids. There is no known way to prevent Kawasaki disease. You must call your healthcare provider or go to the emergency department as soon as possible if your child has symptoms suggestive of Kawasaki disease. We mentioned them before: high fever that persists more than 5 days, bright red tongue, peeling skin, diffuse rash, bloodshot eyes, and the other symptoms that we mentioned. Please be aware that this disease presents itself like many other viral illness or febrile illness in kids. It is a combination of the physical exam findings and the history that should alert you and the physician of the possibility of this condition. It is only with a high clinical suspicion that we're going to pick up these cases and make the right diagnosis.
To conclude, mortality due to KD is rare among children treated with IVIG. Long-term morbidity is primarily related to the degree of coronary artery involvement. Recurrence of KD is uncommon.
Thank you to the organizers. I was tasked with the clinical evaluation of coronary involvement. So for me, when I'm thinking about clinical assessment in Kawasaki disease, I think about echocardiography because they really go hand in hand. So I'm going to talk a little bit about the whens and whys of echocardiography with some tips for imaging potentially consistently so you can get the most accurate data and out of your scans. And talk a little bit about the evolution of coronary artery changes as it relates to our clinical assessment and imaging needs, and then talk a little bit more about integrating our multimodality imaging choices and perfusion tools over time. The diagnosis for most children more than a year of age for Kawasaki's is based on clinical criteria, so you really don't need to do an echocardiogram before starting IVIG if you meet the clinical criteria that Dr. Neuberger went over. However, echo is a vital tool in the diagnosis for those who have incomplete features, as from this very familiar algorithm from the 2017 guidelines for patients who don't have all the clinical features. But I was going to just highlight a few clinical circumstances in particular that I think are worth considering on obtaining echoes in particular, and maybe ones that we don't always think about. So one is if there's infants who have unexplained fever of at least 7 days and they have elevated inflammatory markers. Another group are patients of any age actually, with persistent fever with lack of response appropriately to antibiotics, including those to strep, cervical lymphadenitis, or those who have this nonspecific inflammation or phlegmon in the retropharyngeal area. So this was one of our patients who was an 11-year-old actually, who was diagnosed with Kawasaki disease with this very large right coronary aneurysm dilation. He was diagnosed at day 18, and he had been treated with antibiotics for documented strep, and then also was tested positive for adeno. So you do have to keep a high index of suspicion. Another thing is that you can't put your echo machine away if there are concurrent respiratory viruses, because they generally don't exclude the diagnosis of Kawasaki disease. RSV, metapneumovirus, coronavirus, paraflu, influenza, they can all happen with KD. And in fact, the last 2 KD patients we just saw here at Texas Children's were admitted with RSV bronchiolitis first. And then just to mention about the adeno thing, if it's a positive PCR and there's an exudative pharyngitis and conjunctivitis, then probably KD is unlikely. But if it's non-exudative, then I think you can't exclude Kawasaki disease. Another group is the febrile patient who is suspected to have bacterial sepsis but is not responding to antibiotic therapy appropriately. This brings up the question of Kawasaki shock. There's some information to say that about 7% of patients in continental U.S. do present with shock.